Same thing.
And I would just back it up just a little bit, because I think we've very well covered extractions, and also Clark, I really appreciate the flapping and visualizing first, prior to troughing out and getting really comfortable with troughing out unnecessary bone that's going to be disappearing anyway. There's very few better feelings than just pulling all the teeth with just a forceps and not having to do any rocking and rolling or anything like that. So that's really nice. So, but just to back up a little bit, so we didn't talk too much about local anesthesia. I know that we can really get into the weeds with that, but I do kind of want to provide a little bit of a cookbook just so people can think about the techniques that they really want to be comfortable with. Because I think, for us, like, this can be kind of an oversight, because we just, it's the same thing almost every single time we run through it. But a lot of people are curious about, how do you get patients profoundly numb? So Clark, could you start a little bit, if you're approaching, let's say you're just doing an immediate denture case, let's talk about how you would do an upper and lower anesthesia for that.
So, I do the same thing. 99% of my patients are under, general or, IV sedation. We, 10% of the cases I do my own IVs. The other 90 are general. So it's very rare I get an awake patient, but this is actually very applicable to anybody starting out. Or even if, maybe you're not doing IV, maybe you're just doing oral, right? So you need to keep your stimulation down on these patients. So on a awake patient or a orally sedated patient, the first thing I would do is go in with carbocaine. Carbocaine plain, it is, it's less basic or less acidic, and it doesn't hurt the patient as well, or as much as, say, you're rolling with, some Septo, right? Septo is pretty uncomfortable. So the first thing I'm going to do, I'm going to block the PSA, and then I'm going to go up and get our infraorbital. Okay. So, and I do if I'm not doing zygos, I'll do a intraoral infraorbital block, and do that with a half carpule of carbocaine plain, switch it out, get another half carpule, or get another full carpule of carbocaine plain, do the posterior PSA, and then do the contralateral side where we do the infraorbital. So I do that, let it soak in, and then I'll come right behind that and go into the same spot with 0.5% Marcaine, and PSA Marcaine, infraorbital Marcaine. So now I've used 2 carpules of carbo, 2 carpules of Marcaine. It's taken probably 3 to 4 minutes. That has allowed, some local anesthetic, to where when you give your palatal injection, I've found that the patients are more at ease. And then then I'll go in, give the palatal, right? So we're going to give, bilateral greater palatine and then incisive. I typically would use lidocaine on that. Lidocaine doesn't hurt as much as Septo, so I'll use 2% lido at 1 to 100, and then I'll finish my infiltration of the buccal. So at this point, we haven't done that yet. The reason I want to wait to do my infiltration is because I want my blocks to set in.
Yeah.
So then when we're going, around the canine, when we're going in the anterior, underneath the nose, it's not as stimulating for our patient. And then I will infiltrate the palate with Marcaine. So that covers my approach to the maxilla. And basically that approach is the same whether patient is awake or sedated, doesn't matter. Going on to the mandible, my protocol is very similar. I do a full carpule of carbocaine to get the eye in. I then immediately go back and then I give a Marcaine block. And I will not inject until I hit bone. It's the number one thing. You hear patients are like, oh, he shot me up like 7 or 8 times. Well, the patient will only think I'm doing it once, but, I'm not, injecting a whole bunch of, anesthetic if I don't hit the bone. So I want to hit the bone, inject the anesthetic, and I do 2 carpules. Reason there is the carbocaine makes it, more comfortable. It also allows for faster onset,
Hmm.
and now we're depositing, more anesthetic in around a block where you typically hear that practitioners miss their blocks. Oh, I mean, I will tell you, I get a block 100% of the time
Nice.
um, with that technique. Now, the other key to this technique is that you get the mylohyoid. I can't tell you how many people don't think about that. The mylohyoid is an accessory nerve, and so after I do the IAN block, if they're awake, I'll let that set in for 5 to 10 minutes, and then I'll come back, and then I'll
Hmm.
do a buccal infiltration, and then I do a full lingual infiltration,
Cool.
and so making sure that I get the mylohyoid there.
Great.
So typically on the mandible, on the buccal, and on the lingual infiltration, that's when I'll use my septicane. So if somebody's paying attention, you know, by the time we numb up the entire mouth, we're using lots of carpules, right? But what have you heard? I've used 4 carpules of carbocaine. I've used 4 carpules of marcaine. I've used probably 4 carpules of lidocaine and 4 carpules of septicaine. So that all spread out allows us to stay within our limits. Now, note that your marcaine needs to be 1 to 200,000,
Hmm.
and your articaine or septicaine needs to be 1 to 200,000. So that way we're not overdosing our patients per Malamed of epinephrine. I have never understood that is one of the myths of dentistry is that you can, supposedly give patients too much epinephrine, right? They say what, zero point 0.2 is
Oh,
the
it's
total
insane.
dose,
It's like
right? Okay,
0.04 or something. It's crazy.
something like that. But what do you think our adrenal glands pump out, right? They
Right.
pump out way, way, way more than that. So I I don't think epinephrine toxicity actually exists.
Yeah.
Now cardiac patients and those type of patients, you get that into a lumen of a vessel. I mean, you can cause some pretty big problems with an arterial or
Hmm.
large venous injection of epinephrine. 100%, I agree that happens. But
Yeah.
overdosing patients on epinephrine, I that was never taught to me in school, other than this is a number and you need to memorize it and the state board will come after you for it.
Yeah, and pain is way worse than epinephrine for cardiovascular distress, at least in my experience. So, yeah, I couldn't agree more. Yeah, I think we probably all have small variations on
Mm-hmm.
our anesthetic protocols, but I think that really, in broad strokes, is a very good structure for how to approach full mouth anesthesia. Soren, did you have anything for that?
No, I mean, yeah, and mine's a little bit different. All my patients are fully sedated, so I usually don't go through with carbocaine, but it definitely makes sense to me why you would
Totally.
do that. And I think doing the same thing every single time, whatever your
Yeah.
anesthetic protocol is critical because it just is another thing with efficiency. If my assistants know exactly what I want and I do all my cases the exact same way, it's going to be smooth, it's going to be fast, and
Hmm.
you'll get down exactly how your patients will be properly. Uh, they'll get good anesthesia
Hmm.
for every single patient. So for mine, I do. My patients are sedated, and I do a carp of septo in each quad, a carp of septo on the palate, and then across the whole buccal, I'll do marcaine, and across the whole palate, I'll do a carp of marcaine. So I end up with 3 carps of septo, 2 carps of marcaine on the upper, and then on the lower, I do marcaine blocks on both. Infiltrate with 2 carps of septo throughout, and then a carp of marcaine throughout. Um, so I'm using 2 carps of marcaine on the upper, 3 carps on the lower, and then 3 carps of septo on the upper, 2 on the lower.
Hmm.
Um, I do think using carbocaine first is, especially if your patients are awake, it's
Yeah.
definitely much better. So if you don't have the luxury of sedating all of your patients and under general, I definitely would probably go with Clark's protocol for
Yeah.
sure.
No, that's definitely solid, and I definitely want to make sure it's not overlooked. The mylohyoid is very important, and just getting comfortable with floor of the mouth infiltrations that will save you a whole lot of frustration because that can definitely be a particularly seedy one. And I think a lot of the issues that people have with their IEM blocks are actually just ignoring the accessory innervation. So that's really good. And two, Soren,
Totally.
you bring up such a good point about just whatever it is that you're doing, as long as you're able to achieve profound anesthesia, as long as you're getting teeth out efficiently, standardizing your cases to where you have the same protocol for everything. I mean, pretty much the way I approach an immediate denture is very similar to how I'm going to approach like a full arch remote anchorage type case, because I've just been doing it the same way practically every single time. There might be some modification here and there, but if you're doing it the same way every time, you're making every case similar, then you're going to be able to build on that experience more efficiently with every case. And then we also talked about flapping and visualization. So this is something that I'm super anal about. There's not a whole lot of things when I'm mentoring that I'll be like really strict about in OCD, but this is really the big one. So we already mentioned full mouth retraction. So we talked about O-ringers. I usually use a hard G on the GER, but I've definitely heard the soft G with O-ringer. Who really knows? But that's great. Optrogates are good. You can also use a combination of the two where you have the Optrogate and then the O-ringer over the top of it. That works too. Mm-hmm. Just making sure that you can see the whole mouth at the same time. I also encourage less magnification. I hate when I shouldn't say I hate, but when I see people trying to use like 3 times or more magnification on full arch cases, it's literally just myopia in full arch, and that should be a bad word. Personally, I just wear safety glasses, and illumination is super important. You don't necessarily have to go all the way with like a quad lumix or whatever is on the market nowadays. Personally, I just use a little luminant light, but as long as things are adequately illuminated, that's super important. And then when it comes to flap and visualization, so we may have different philosophies here, but what's really important to me is the incision design. Some people will extract first, some people will incise first. I really do like Clark's advice about going ahead and getting everything incised and flap first, at least to start off when you're trying to get comfortable with these techniques. For me, that means going on the maxilla, we're going from the distal of the tuberosity, kind of going over that heel, as I like to call it, as it sort of dips behind the tuberosity all the way to the other side. It's a little bit hard to illustrate purely over audio, but also you can get comfortable with buccalizing your incision just slightly so that you can create a straight line incision such that after you've created that incision across the arch, you can then just flick off the papillae. It's really nice to have very straight incision lines. They're easier to suture. It's much cleaner. You don't get weird bunched up tissue in places. It's going to throw off the fit of the denture. So getting really comfortable with, kind of seeing the end in mind. You want to, create those very clean incisions, preserve keratinized tissue. Even if you're just doing an immediate denture, make sure that that's going to end up in a good spot, because this patient may get implants later and you want to be really, comfortable with that. Once you've created that incision, reflecting with either a Molt 2.4 or a Molt 9 are really great instruments, and using your Minnesota for tension. So after you've gotten the reflection started, personally, I like to do some vertical releases up the zygomatic arch. I think that's a good practice to have. It'll benefit you as you go further along your journey into remote anchorage and things. And there's absolutely nothing to be lost by throwing in a vertical incision, even on an immediate denture. So you start that flap, you're going to reflect things back, focusing on very full thickness mucoperiosteal flaps. They bleed less and they just fly off the bone if you start them right, making sure you're cutting very hard, staying on bone, getting that flapped. What we're wanting to see on the maxilla is I want you to visualize the nasal floor. It seems like it's really far up there the first few times you go up there, but it's really important to be able to visualize that, releasing those muscles, releasing all that periosteum, and getting a really nice, beautiful white bone reflection of the maxilla is just so critical, and such that you're not having to fight your flaps. The flaps aren't trying to reattach throughout the surgery, because that becomes a huge waste of time, tires out your hands, you get a bloody field, it's gross. So you want to get really comfortable with making things really nice and pretty. On the lower, very similar. You're going retromolar pad to retromolar pad, little hockey stick incision, a little vertical incision, sort of like if you're doing like a third molar extraction is a good thing to get comfortable with. Releasing distal forward and getting things really nicely visualized. Practicing, of course, identifying the mandibular foramen. That's a huge one. I'm getting really comfortable for visualizing that. I find it much easier to do that when I'm over the top of the patient, because it's much easier to see that depression of the bone as you're reflecting from distal forward. So that's a really good thing to have. And then generally on the lower, I will reflect the buccal flaps. This is enough visualization such that I can do exactly what Dr. Damon was talking about in terms of doing the buccal troughing, getting interceptally between the teeth and reducing all that bone support. And then I'll get the teeth out. And then usually that is when I will do my lingual reflection. I find it sometimes very difficult to get a nice lingual flap when there's still teeth. So if I'm doing a full arch, I'm going to go ahead and get the teeth out of the way. And then I'll just take usually my Molt 9, start in the distal region, kind of near the mylohyoid. I'm going to slip that elevator right inside of it, and then I'm going to tilt it such that sort of the anterior portion of the Molt 9 is just on bone, and then I'm just going to slide it forward, and you'll see that whole lingual flap just fly right off the bone. It's really nice. Obviously, you want to be really careful with some vessels and things. You don't want to be really deep when you do that, but it's a really nice way to get the lingual flap reflected pretty quickly. And while you're at it, right just prior to starting your alveoloplasty, go ahead and practice some tiebacks. Get palatal tiebacks, lingual tiebacks. Get that tissue out of the way, because at the end of the day, what's really important here is visualization, illumination, and just isolation of your surgical field before you start touching it with a rongeurs or an alveoburr, what have you. So that's kind of my big spiel on visualization. Is something I'm really passionate about. I hope that wasn't word vomit.
No, definitely.
I think that for sure, getting the teeth out first before you do your lingual, hands down, and just mentally, this becomes a very tactile, thing. Getting the tissue off is very tactile. All I care about is, do I feel something hard, right? If I don't feel anything hard, then I know that I'm deep into some tissue, or I'm not where I need to be. One instrument that I will use that will help me get the lingual of our mandible degloved is using a curette. And so, the curette is kind of curved. So I use that curved in that is scooping against the bone, and I will actually use that and push it down. And, to your point about in the maxilla, when we go up and we do our reflection, if this is a full denture case, you've got to be able to get a burr in there to smooth off that canine eminence, right? So some docs are like, golly, why do I got to go to the nasal floor? Well, you at least need to be really close to it. I don't necessarily think that you have to get there and see the nasal mucosa, but you definitely have to get past the canine eminence all the way down, and that's actually potentially deeper than where the floor of the nose is with that nasal mucosa.
Sure.
So my guiding principle whenever I'm doing a denture, the number one thing that I don't want to have to do is revisional alveoplasty. I can't tell you, how many consults, that I would see on a month, per month basis. It'd be like Betty Sue comes in, can't wear her denture. The first thing I say, when did you get your teeth out? And she's like, 2 months ago. I'm like, yep. She's like, can't wear the dentures. I'm like, nope. Did you get stitches? Nope. Right? Every time. Right? So, that whole scenario plays out all of the time. So yeah, getting started in full arch is not just about like, oh, can I take out teeth? Like that's the minor beginning. It's like, okay, well, can you reflect the tissue well enough? Can you take the teeth out efficiently? But then, were you also able to deal with restorative space? Were you able to manage, overall patient aesthetics when they've got a denture and a big flange? Did you perform pre-prosthetic surgery well, right? So when I was flying up here today, I was on the airplane and I was kind of thinking about our little chat tonight, and it's kind of like guys that want to, or doctors who want to get into this, want to get into full arch. Well, you better be ready to solve some problems, right? Because right off the bat, we can take teeth out, but I've got a list of 5 or 6 different problems that you now have to manage or deal with. And somebody wanting to get started in this, one of the problems that you got to do is you got to deal with making dentures first, right? Yeah. So this isn't just a blood and bone thing. There's a huge prosthetic thing here, right? So these doctors have got to deal with how do you get one of these cases set up, right? Are they edentulous? Are they completely edentulous, and maybe that you're just dealing with some alveo? Or are they partially edentulous? How are you going to develop your occlusal plane? Where are you going to set your incisal edge? How are you going to deal with vertical? How are you going to get started? I can't tell you. My lab would make cases for outside doctors, and they'd give us 2 models without a bite, and the teeth
Mm-hmm.
don't even go together, and they say, make us some dentures. And it's like, whoa, okay, you missed the whole part about, jaw relation, vertical, and it's obviously one of these cases where it's like they have back teeth on the maxilla, no back teeth on the mandible, and then anterior teeth on the mandible and no anterior teeth in the maxilla. And so it's just total combination syndrome. And it's like, if you're going to get into this, sure, there's a whole surgical component, but you now have got to deal with, how do you make dentures? Where do you set the teeth? How do you work with a lab? So there's a lot that you got to, go back and do, and doing that well sets you up for your later in your,
So true.
journey for full arch.
Yeah. I
So
think the basics for doing full arch is making a denture.
Yeah.
A lot of the same principles apply as far as, where the teeth are set. And something that I did early on with my assistants, because my assistants are taking a lot of my records for me, and I'll check them all, but I went back to my dental school removable course, and I took that and I gave it to the assistants, and I said, here, I want you guys to look. I took, the important slides, right? Had them read through that so they understood the basics. And if you're a practicing dentist who might need a little review on those basics, if you still have some of those slideshows, maybe go back and just read through them. It never hurts, and I do think that those basics for making a denture is going to go a long way for your denture cases, your overdenture cases, and then your fixed cases when those come. One thing I wanted to say quick, just about going back to what Tyler was saying about reflection, is make sure that your assistants are helping reflect as well. I see so many doctors when I go to clinics, and their assistant, they have, just their 2 suctions in their hand, and that's it. My assistant always has a Minnesota in one hand and then a surgical suction in the other, and they're helping me reflect those tissues to make sure, before an alveoloplasty, my assistant always has if we're doing the lower right, like, she has a sweetheart and she's reflecting all of that tissue back. I have my Minnesota, I'm reflecting the buccal tissue, and that way all of those vital structures on the lingual side are reflected back. It should be just, you shouldn't be able to see any of those tissues, and you don't have to worry about hitting any of those arteries or glands that are in that region. It's critical to utilize, the people that you're with, and it'll go a long way for preventing any disastrous effect, like a tongue wrapped around your handpiece.
Yeah, I mean, and both of you bring up some really powerful points. I mean, definitely we could kind of go back to when we were talking about, didactically what you need to be covering before you get into this. I mean, what's the point of learning, as a dentist, what's the point of learning all this surgery and learning how to do this efficiently if you don't know your denture concepts? Because when you're putting these patients in teeth and they're having phonetic or aesthetic issues, functional issues, all of that comes back to dentures. It doesn't matter if it's a fixed prosthesis, removable prosthesis, what have you. Those denture concepts are extremely important. And then when Soren is talking about with, recruiting the people that, are working with you, there's definitely an art to, you can have that assistant that's just pulling suction and just kind of like supporting you as an auxiliary. And then you have someone that's actually like really helping you work through the case, and someone that's helping you reflect tissues, keep vital structures out of the way. That's invaluable, and that can definitely make you a lot more efficient and help you do things a lot safer. So I think both those points are very well taken. That's something you can be working on, through this entire journey from the very beginning. And starting on the right foot is definitely going to, pay some dividends the further down the journey you go, for sure.
Yeah,
So,
I mean, dentures, you got to remember, dentures need restorative space. You need 2 to 3 millimeters for your denture base. And then, emergence profile actually exists. We always think of emergence profile with like, fixed arch or even a single implants.
Yeah.
Emergence profile also exists for the denture teeth, right? Like, where are they in relation to the denture base, which is in relation to, the bone and the gums, also, sometimes we've got to do larger pre-prosthetic surgery, reducing the alveolus from the buccal perspective, right? So if you see somebody that just already aesthetically has a very thick lip, due to, their bone structure, and you're setting them up with the denture, what are you going to add on top of that, right? You are
Yeah.
going to add, another 2 millimeters of a flange. So you got to be thinking those things through. And, some cases, also requires model surgery, right? So like, your tooth setter or, whoever's setting your case on the lab, sometimes you need to say, you know what, I need you to articulate this. And before you set the teeth, send it back to me because I need to do model surgery and then I'll give it back to you. So that way they know, where to set the teeth and stuff like that. I mean, it's easy for me. I mean, I have my tooth setters in office, right? But not everybody has that set up.
Yeah, that's a great point too. And when we were talking about picking up days in an affordable or any denture and implant clinic or what have you, having the luxury of having a tech that's there is huge, because otherwise these lessons are going to be a lot harder to learn when you're having to send cases back and forth from an external lab. So I definitely think that in that respect, just having an in-house lab while you're trying to learn these things is it's going to expedite your journey as well, and probably be a whole lot less frustrating. That interplay between the doctor and the technician is huge, and that goes all the way. Even when you get into digital and things like that, like being able to communicate effectively and pre-prosthetically playing these cases is just so huge. And that goes from dentures all the way up. So points well taken.
for sure.
And one other problem I thought that was interesting that I want us to kind of talk about
Sure.
is, where do you get denture patients, right? Like if you want to get into full arch, but you got to take dentures as the first step, where do you get them? They just don't show up, right? You have to actually actively target them, right? So you've got to, create marketing, etc. But what do you get with denture patients? You get fixed arch patients.
Oh yeah,
right?
you bet.
Okay, so now you have a doctor who doesn't do fix full arch, but yet wants to get denture patients in the door. But then a third or more of your patients are going to want, hey, there's this permanent thing, I want to get that, right? So like that's a legitimate problem that somebody starting out really needs to think through. And my advice to that is, sure, we love our referring oral surgeons. Definitely use them when needed. But one thing that you can do instead of just referring that case out is see if you can get somebody to come in your office, right?
Mm-hmm.
Soren, I know that you bring in an anesthesiologist or a CRNA. You have probably learned excellent sedation abilities because you bring in an outside provider. You have seen when shit hits the fan, and you've probably been able to manage an airway that you may not have, been able to before. You may have seen a medical condition happen when you have another medical colleague. And so you learn from that, right? So the same thing, if you bring in an outside doctor who can say, hey, doctor, you do all your dentures, and then, the bycatch that you get, the arches that you get that you're not ready to do, hey, I'll come in and do them, and you can be there. I mean, think of the learning opportunity right there, right? So now your patient is paying for your CE, and you're able to provide that service within your office. So anybody who's out there, don't feel like, oh, I don't want to market to dentures because I don't want to get these fixed patients, but then I don't want to do fixed because I haven't done denture, right? So it's kind of like a chicken and egg thing. Just I'm sure there's plenty of hungry guys that would want to come in and make $1 or $2 and do some arches in your office.